Hypothyroidism is one of the most common conditions that I see missed in practice. And it's not because clinicians don't care, it's because the condition itself rarely looks dramatic. Most people don't wake up feeling unwell. In fact, what happens is most people slowly stop feeling like themselves. And here's the part that patients are rarely told, that your symptoms don't really match your blood test results. And that mismatch is where so many people are told everything is fine and everything is normal, yet still feel awful. Hypothyroidism is usually slow, quiet, and gradual. Sometimes it takes months or years for it to develop, and people do adapt. Some things that patients do describe are things like brain fog or constipation or dry skin or hair thinning, fatigue, low mood, menstrual changes, fertility issues, weight gain, or excessively feeling really cold when nobody else is. And this is important. Not everyone will have all of these symptoms. Some people may just have one or two. Symptom severity does not reliably correlate with TSH, meaning someone with borderline results may feel awful and someone with relatively high TSH may feel okay. This is why relying on numbers alone causes problems. Because symptoms creep in slowly, people tend to normalize feeling unwell. They tell themselves it's because of stress or age or because of work or just menopause or life itself. And by the time they seek help, the story can be quite hard to untangle. There usually isn't one single reason. It's normally an overlap of smaller ones. Firstly, the symptoms are usually non-specific: fatigue, weight gain, low mood. These overlap with almost everything. Secondly, the gradual onset affects how symptoms are described. Some patients may come in and just say, I just don't feel right, without being specific. Thirdly, early blood test results can be falsely reassuring. For example, TSH might be borderline, it may fluctuate, and one test result may come back normal, which shuts down further thinking. Sometimes blood test results are interpreted without enough clinical context, and patients leave feeling unheard while clinicians are left falsely reassured. This is one of the most misunderstood areas. Reversibility depends on the cause, not the TSH number. Hypothyroidism isn't just one disease, it's a biochemical state with multiple causes, and that can be temporary or lifelong. Subclinical hypothyroidism is a common example. This is when your TSH is mildly elevated, but your free T4 is normal. So if your TSH is under 10, then your thyroid function is likely to normalize over time. And in these cases, it's usually quite appropriate to monitor instead of starting immediate treatment. Another example is thyroiditis. Postpartum thyroiditis or subacute thyroiditis often settles spontaneously. There is, although, a minority of people that do go on to develop permanent hypothyroidism. That's why reassessment really matters. Drug or iodine-induced hypothyroidism is another example. Remove the trigger and the thyroid function may actually recover. And in these cases, long-term levothyroxine may not be necessary. In UK primary care, subclinical hypothyroidism is extremely common. It's often picked up during fatigue investigations, fertility workup, or cardiovascular screening. Under UK guidance, the approach is quite conservative. If the TSH is persistently above 10, you would consider treatment, and if the TSH is below 10, you may consider monitoring. Here's an important reality from practice. A lot of people started on levothyroxine years ago for borderline results and never reviewed. There's now increasing emphasis on revisiting why treatment was started and whether it's still indicated. Pregnancy changes everything. TSH reference ranges are different, non-pregnant ranges don't apply, and subclinical hypothyroidism is treated more proactively. Many women have their first thyroid function testing during pregnancy, receive treatment appropriately, and then end up on levothyroxine indefinitely. Postpartum reassessment is essential, but often is missed. Autoimmune hypothyroidism, Hashimoto's, is typically long-term. Hypothyroidism after thyroid surgery or radioiodine treatment, these conditions aren't expected to reverse. That's not to say that symptoms cannot be managed well, they absolutely can, but expectations need to be realistic. Reassessment may be appropriate if treatment was started for subclinical borderline disease, the treatment indication is unclear, hypothyroidism followed a transient thyroiditis. Any dose reduction or trial of therapy should be planned, supervised, and followed up with repeat TSH and free T4. This is not something to do casually or without a follow-up. There is no dietary or supplement that can cure autoimmune hypothyroidism. Nutrition definitely helps health, but it doesn't replace thyroid hormone. Iodine is relevant in the UK. Mild deficiency does exist, particularly in women of childbearing age, vegan diets, dairy-free diets, but excess iodine can worsen thyroid dysfunction. So unless indicated, high doses of iodine supplements should be avoided. Selenium, zinc, vitamin D, all very important if deficient, but there's no strong evidence to suggest that they treat hypothyroidism itself. Exercise doesn't fix thyroid hormone production, but it helps almost everything else. Mood, fatigue intolerance, cognitive function, cardiometabolic risk. The aim is consistent activity or movement, but not pushing through exhaustion. If symptoms persist with a normal TSH, it's worth considering absorption before increasing the dose. For example, timing with food or coffee. Calcium, iron, fiber all inhibit levothyroxine absorption. Protopump inhibitors affect levothyroxine absorption. Gastrointestinal conditions and other things that cause fatigue, iron deficiency, B12 deficiency, sleep disorders, mood, perimenopause, post-viral syndromes. So let's recap. Hypothyroidism can be reversible depending on the cause. Autoimmune disease is often long-term but very treatable. And diet and supplements are adjuncts, not treatment. The wins come from correct diagnosis, optimizing absorption, and addressing comorbidities. Thank you so much for watching, guys, and I'll see you in the next video.